Prognosis presents MedBrief.
For decades, clinical medicine has treated the body as a collection of independent systems. A cardiologist managed the heart, a nephrologist managed the kidneys, and an endocrinologist managed blood sugar. But clinical data reveals that organ failure rarely happens in isolation. When metabolic dysfunction directly collides with renal decline, it creates a systemic feedback loop that accelerates cardiovascular collapse. We now classify this interconnected pathology as Cardiovascular-Kidney-Metabolic, or CKM Syndrome. It is a single progressive disease state where dysfunction in one system directly drives deterioration in the others. The 2026 AHA, ACC, ADA, and ASN multi-society guidelines formally dismantle the isolated approach to these organs. They establish a new operational standard that forces clinicians to assess and treat the entire CKM circuit simultaneously. This source graphic from the guideline illustrates the core biological mechanism. You see the kidneys, the heart, and the pancreas locked in an infinity loop. This represents how metabolic risk factors intersect directly with the physical progression of chronic kidney disease and cardiovascular disease. The overarching objective of the 2026 framework is to intercept this cycle. It mandates routine interdisciplinary assessment across all three systems and the early deployment of highly targeted cardioprotective therapies before end-stage damage occurs. Crucially, the guidelines go beyond simply slowing decline. By intervening at specific metabolic thresholds, the actual regression of CKM stage is possible. Managing multi-organ failure through clinical silos allows compounding pathophysiology to go unchecked. Establishing a connected clinical framework is the only effective way to track this disease and stop cascading failure across the vascular, renal, and metabolic systems. To operationalize this, the guidelines implement a universal 5-stage tracking system for both youths and adults. It begins at stage 0, representing no CKM risk factors, and scales up to stage 4, denoting clinical cardiovascular disease with overlapping kidney or metabolic failure. Moving a patient through these stages requires strict, ongoing assessment. Clinicians are required to measure specific metabolic risk factors, kidney function, and cardiovascular status. Detecting these inputs early identifies the subtle transition from asymptomatic risk into active stage 2 progression. Once risk is identified, the Class 1 first-line strategy is aggressive lifestyle modification. Clinicians must provide counseling aimed at facilitating a 5% to 10% reduction in the patient's baseline weight. That 5% to 10% threshold is an active biological lever. Achieving it directly reduces systemic inflammation and insulin resistance, driving tangible CKM syndrome stage regression. The framework also introduces a Class 1 recommendation to evaluate adverse social determinants of health. Medical intervention alone is insufficient if environmental risk factors are ignored. Conditions like housing instability, food insecurity, and economic barriers directly limit a patient's ability to maintain a healthy diet or adhere to complex medication schedules. These social determinants accelerate the development of CKM syndrome. Tailoring therapy to a patient's absolute clinical risk requires mapping their biological staging precisely alongside their social determinants. Without both, the clinical picture is dangerously incomplete. To classify late-stage disease accurately, subjective clinical judgment is replaced by a quantitative engine, the PREVENT equations. This calculator uses patient data to estimate the 10 and 30-year risk for atherosclerotic cardiovascular disease, heart failure, and total cardiovascular events. The guidelines establish strict diagnostic thresholds tied to this output. If a patient's PREVENT calculation hits a 20% predicted 10-year CVD risk, they meet a defining criterion for CKM stage 3. But intervention must happen earlier. When the predicted 10-year CVD risk crosses a much lower 7.5% threshold, it triggers an immediate shift in strategy, prioritizing the introduction of advanced pharmacotherapies over lifestyle changes alone. Accompanying this risk calculation is a rigorous schedule for kidney assessments, required for all adults currently in CKM stages 2 and above. Clinicians have a Class 1 mandate to measure both estimated glomerular filtration rate, or eGFR, and the urine albumin to creatinine ratio, UACR, at least once a year. Relying on a single metric masks underlying renal damage. For patients presenting with diabetes or 2 or more cardiometabolic risk factors, another specific diagnostic is mandated, the fibrosis-4 or FIB-4 index, which must be calculated every 1 to 2 years. The FIB-4 index calculates the risk of severe liver fibrosis. Including this in the standard workflow ensures that clinicians catch undiagnosed metabolic dysfunction-associated steatotic liver disease, a silent accelerator of cardiovascular risk. Asymptomatic progression into late-stage organ failure leaves no physical clues. Strict adherence to the PREVENT calculation and dual kidney assessment and FIB-4 scoring schedules forces the underlying pathology into plain view. This guideline chart maps out exactly how to deploy specific drug classes as circuit breakers within the CKM loop. It links strict diagnostic thresholds to specific nephroprotective and cardioprotective agents. Looking at the type 2 diabetes pathway, if a patient is in CKM stage 2 or 3, meets these specific fasting glucose or HbA1c criteria, and has a PREVENT risk above 7.5%, the treatment plan must include an SGLT2 inhibitor or a GLP-1-based therapy. The guidelines mandate these agents for their proven, independent ability to reduce cardiovascular events and all-cause mortality, elevating them from blood sugar management tools to primary cardioprotective therapies. For chronic kidney disease, the algorithmic first line of defense is clear. If a patient's UACR is 30 mg per gram or higher, clinicians must prescribe a renin-angiotensin system inhibitor, a RASI, at the maximum tolerated dose to prevent renal function loss. If that UACR climbs to 200 or higher and their eGFR remains at or above 20, the guidelines issue a Class 1 recommendation to introduce an SGLT2 inhibitor immediately to lower the risk of heart failure hospitalization. If albuminuria persists despite maximizing RASI and SGLT2 inhibitors, the protocol forces an escalation to advanced additive therapies. A UACR remaining at 30 or above indicates the addition of a nonsteroidal mineralocorticoid receptor antagonist, or NSMRA. If the UACR remains at 100 or above, clinicians must add a GLP-1-based therapy for further kidney and cardiovascular protection. This replaces subjective prescribing with a strict data-driven algorithm. When specific lab thresholds are crossed, the protocol forces the deployment of the exact agent proven to intercept that specific organ failure. This required integration extends into specialized heart failure workflows. Adults with a predicted 10-year heart failure risk above 5% must undergo evaluation with specific cardiac biomarkers to detect pre-heart failure before symptoms emerge. Once clinical heart failure develops, SGLT2 inhibitors serve as the foundational, first-line guideline-directed medical therapy. This applies across all major subtypes, regardless of ejection fraction. For heart failure with reduced ejection fraction, or HFERF, the standard is quadruple therapy. This combines beta blockers and steroidal MRAs with the dual kidney and cardiovascular protection of RASI and SGLT2 inhibitors. For patients with preserved or mildly reduced ejection fractions, the strategy targets comorbid metabolic drivers. If these heart failure patients present with obesity, GLP-1-based therapies are introduced directly into their regimen. If the patient presents with the specific clinical overlap of heart failure, type 2 diabetes, and chronic kidney disease, nonsteroidal MRAs are indicated to aggressively target inflammation and fibrosis. Deploying these specific drug classes across the ejection fraction spectrum interrupts the systemic CKM feedback loop, directly driving down both hospitalizations and cardiovascular mortality. The operational urgency of the 2026 American guidelines becomes clear when contrasted with the 2023 European Society of Cardiology guidelines regarding diabetes and cardiovascular disease. The ACC establishes a strict Class 1 mandate for early intensified multifactorial interventions. It requires clinicians to deploy lifestyle changes and targeted pharmacotherapy simultaneously. The European approach is markedly more conservative in its primary prescribing triggers. In the American framework, a 10-year PREVENT risk of just 7.5% acts as a definitive Class 1 trigger for SGLT2 inhibitors and GLP-1s. The ESC, using the SCORE2 diabetes calculator, treats a higher 10% risk merely as a Class 2B consideration. The ACC also employs metformin specifically as an early Class 2 adjunct, combining it with cardioprotective antihyperglycemics to rapidly achieve glycemic targets. The ESC guidelines lack a direct equivalent for this precise adjunctive combination strategy. The American framework demands medical intervention based on an absolute risk prediction, rather than waiting for the physical presence of atherosclerotic cardiovascular disease to justify advanced therapies. By treating projected risk with the same urgency as existing disease, the ACC requires a far more aggressive primary prevention model, designed to halt irreversible end organ damage before it clinically manifests. Executing these multifactorial algorithms requires abandoning traditional clinical structures in favor of a fully integrated, interdisciplinary care model. To manage the overlapping pathways of type 2 diabetes, CKD, and cardiovascular disease, clinics must designate a CKM coordination point person. This ensures the cardiology, nephrology, and endocrinology workflows are unified for the patient. The diagnostic baseline is non-negotiable. It requires routine dual kidney assessment with eGFR and UACR, paired with scheduled FIB-4 scoring to actively hunt for masked progression. The 2026 AHA, ACC, ADA, and ASN guideline forces clinical practice to evolve. It uses prevent risk calculators to drive the early, aggressive prescribing of protective drugs like SGLT2 inhibitors and GLP-1 agonists. By mapping these precise diagnostic thresholds and coordinating treatment through a unified clinical team, you establish the necessary framework to break the cycle of connected organ failure and drive tangible CKM stage regression.